Looks like our recording is working. And if our speaker would like to introduce himself, Bill, we would really appreciate that. And thank you so much for taking the time to share with us today. We really appreciate it.
Well, this is really a great pleasure for me, and thanks for the invitation. So probably my most important credential is that I'm an FOC. I'm a friend of Carolyn, and I'm also an FOT. Tricia and I have now overlapped a fair bit, but Carolyn and Tricia call, I say yes, because, you know, y'all do just such fantastic work. And so, you know, and greetings, by the way, to Family Voices of Minnesota from Family Voices of Wisconsin. I'm on the board of Family Voices of Wisconsin. And so I love the fact that we also get to connect in the ways that we get to connect now. And we've done some previous things together where you've invited me to participate, and I really appreciate that. I'm coming to you as a family physician. I work at the University of Wisconsin Department of Family Medicine and Community Health, where I'm a faculty member, and I'm currently the interim chair of the department. And my practice includes about a third people with disabilities, children and adults across the lifespan, and has a focus then on the care of people with special healthcare needs. And also within that has been work over nearly 30 years with the Institute for Patient and Family-Centered Care. I'm on the board of directors and teaching faculty of IPFCC and had a role in getting that established. And you'll see that logo through this because really the presentation I'm giving you grows out of all the work that we've done at the Institute to try to advance the practice of patient and family-centered care. And I also come to you with experience as the parent of a child with special healthcare needs earlier in life, and at least some insight into the family experience based on that as we have this conversation today. And what I want to talk about then is really collaboration in the context of family-centered care. And I know you know much of this, but I'm hoping that what I can do is bring it together in a way that is useful for you as you do the great advocacy work you're doing. I read poetry. My favorite poet is Wendell Berry, who lives in Kentucky and I think has a wonderful take on life and a wonderful way with words. And one of his poems that always touches me the most is called Our Real Work. It may be that when we no longer know what to do, we have come to our real work, and that when we no longer know which way to go, we have come to our real journey. The mind that is not baffled is not employed. The impeded stream is the one that sings. And I think for those of us who have experiences, parents of children with special health care needs, I think there are many times where you weren't sure which way to go or what to do. You didn't feel prepared for the journey you were on and the work that you were needing to do. And you felt like somebody else probably knew how all this stuff worked, but your mind was baffled. But you know, the mind that's baffled is not employed. And I love this image of the impeded stream, because that's the sound of water going over rocks. That's the rapids. And that's really what we hear singing. And for each of you and of us, we've been on the rapids of life from time to time. And it's great to have those tools and recognize that we're doing our real work and that we're on our real journey. So when we talk about patient and family-centered care, lots of people talk about this. I mean, I said the Institute for Patient and Family-Centered Care, we've been up and running for 30 years. The term family-centered care was originated by C. Everett Koop when he was the Surgeon General in 1987. Came up with this notion of family-centered care, and it came out. And every health system you deal with children is talking about what they're doing in the realm of patient and family-centered care. So you'll find these statements on the websites of whatever fine institution you go to receive care. Gillette will tell you, as I know they believe deeply, You and your family are truly at the heart of your child's care team. At Children's in Minnesota, we encourage patients and families to participate as active members. We respect their role. Minnesota Masonic will say we deliver exceptional and seamless patient and family-centered care, and Mayo is the family-centered children's hospital. And your healthcare homes, which really are strong, have talked about team-based coordinated patient-centered care. It's really patient and family-centered. So this is at the heart of the way healthcare sees itself as delivering care. And for many, it's also a strategy. It's also sort of the way that they come together to approach care. But as Peter Drucker said, culture eats strategy for lunch. If a healthcare organization simply sees patient and family-centered care as a strategy, but hasn't infused it completely into the culture of the organization, into the way business is done, well, you're not going to experience that patient and family-centered care because the culture of the organization is most important. And so a part of what I want to talk to you today about is how to recognize, how to advocate, how to assert how patient and family-centered principles truly need to be in all aspects of the culture of an organization. Well, let's start with definitions. And at the Institute, we have coined this definition, which by and large is accepted by most around the country when we talk about what we're talking about with patient and family-centered care. And I will pause to say that I am talking about patient and family-centered care, recognizing that children, sometimes very young, still have their views on how healthcare is delivered, and they have a role in this. And children who may be perceived as having limitations in the way that they communicate, as we know, communicate very well what their opinions are and what their preferences are. And we want to take that into account as we also respect and honor the role of families. So when we talk about patient and family-centered care, we're talking about an approach to the planning, delivery, and evaluation of healthcare that is grounded in mutually beneficial partnerships among healthcare providers, patients, and families. Mutually beneficial partnerships. Obviously, people who are receiving care are looking for something important from the healthcare system and in the healthcare equation. But we too have something to contribute to that. That is those mutually beneficial partnerships. And those of you who are working or training in advocacy roles, you're training to be partners who are contributing benefit and value to those healthcare systems. It's a reciprocal relationship. What are the principles of patient and family-centered care? Well, first, people are treated with respect and dignity. And we all want respect and dignity. And one of these days, I'm going to invent a dignitometer, and that's going to tell us whether respect and dignity is happening, or we're going to be able to get serum respect levels when we do blood draws and know whether it's there. But until I get that perfected, the only way to know whether respect and dignity is happening in an organization is to ask you. But I want to note, it doesn't say patients and families are treated with respect and dignity. It's people. And people includes staff, and it includes clinicians and providers and leaders and administrators. Everybody in that organization is treated with respect and dignity. And we actually know that if respect and dignity isn't happening at the level it should for staff and clinicians and therapists and others, if it's not happening for them, then it's typically not happening for patients and families. Some of the time, though, I have seen places where the premium on respect and dignity for patients and families has really exceeded the experience of those delivering care. And that mismatch is really painful for all of us and creates real challenges in healthcare. Next principle is that healthcare providers communicate and share complete and unbiased information with patients and families in ways that are affirming and useful. And that's a really important clause there at the end. Everybody talks about sharing information, but the key is, are they sharing information for a reason, for a purpose? And it's in ways that are affirming and useful, that help you live your lives, do your thing, make it happen for your child, your family, your neighbors, your friends, other people you're advocating for. Next, it's individuals and families build on their strengths through participation in experiences that enhance control and independence. Again, there's a purpose to that participation. It's to enhance your control and independence. What every family member wants is, we want to do it ourselves in an easy system, one that is responsive and that works for us, as opposed to always needing to feel like we have to go through some complex system to make things happen. And participation is a strategy in this. Now, this is a change in the reflexes of healthcare providers. We've been taught over the years that a part of our compassion is that you can just kind of sit back and we'll do a great job for you, and this should be something that you don't have to worry about. But it turns out that the more passive you are in the healthcare equation, the less you feel like you have control and independence, and actually the less able then you are to continue care outside of the healthcare realm. So participation is really important to quality care. And finally, collaboration among patients, families, and providers occurs in policy and program development, as well as in the delivery of care. And so I want to be very clear, I'll say this about 10 times. This isn't just about the interaction that happens in the exam room. This is about the policy and program development level, as well as education. And that we're talking about the involvement of patients and families at all of those levels. Sometimes when we talk about this, it all sounds kind of nice abstractly, but it helps to have a thought about what does it mean in reality. And so one way is to imagine the driving forces of healthcare. What makes things the way they are? And so we can imagine a system-centered driving force. As an alternative to thinking about what's patient and family-centered, what are the alternatives? Well, how about system-centered care, in which the priorities of the system and those who work within it drive the delivery of healthcare? This doesn't mean that healthcare professionals, leaders, administrators are being mean and nasty in what they do and don't really care. There is this sort of feeling that, look, if we can make the system work for us, then we'll be able to do a better job for you. That, however, may not take into account the things that are critical and important to you. And as an illustration, here's a thought about what system-centered care looks like. Everybody in their individuality at the top of the screen there comes to the healthcare equation, and what happens is they kind of go through the system and out as widgets. And the healthcare providers are on the side pulling the strings and pushing the buttons and making things happen, not really interacting with the people receiving care or each other. That's system-centered care. But of course, we don't think of ourselves that way as healthcare providers. We want to focus on our patients and do the best for them. So a patient's focus driving force, hey, we focus on our patients, has the patient as the focus or unit of care. Interventions then are done to or for that patient instead of with the patient, and the patient is not viewed within the context of family or community. Here's an example of patient-focused care. It's all about the child. You're just, as a parent, you're just one of them little people up there on the head or the shoulder or the tail or whatever who are there, but it's really about the child. And notice the care providers who are holding the strings, they're not interacting with each other. They're each in their own kind of silos and world, each individually focused on that patient. But we know that folks have figured out that children do have families, and so there can be a family-focused driving force with the family as the focus or the unit of care, and interventions then being done to and for them instead of with them. And here's a thought about what that looks like. Families, you probably have experienced this. You feel like you're under the microscope or under the magnifying glass. The professionals are checking you out. I learned that we would meet with families, and then we, the professionals, would go back to another room and talk about them, and then come back to them and make our recommendations as professionals, our pronouncements about what needs to happen. That's not partnership, that's focusing in a way that is not authentic partnership. And so finally then, by contrast, we're talking about patient and family-centered care as a driving force in the way healthcare is delivered. The priorities and choices of patients and their families drives the delivery of healthcare. That doesn't mean it's not in consultation, partnership, collaboration, and all of that with the people in the healthcare system. It just means there's an understanding of the priorities and choices of patients and their families. And of course, the only way you can know that is to have real partnerships, real collaboration, real connection to ask that, and to use that information to drive the delivery of healthcare. And what you're waiting for is me to show you this beautiful illustration of rainbows and unicorns and all of that will be, the patient and family-centered driving force. And this is what I'm going to give you, because this is your canvas to create. I can't give you patient and family-centered care in a box. I can't give you a formula for that and say, just do this. This is the system. It's the same whether you go to Mayo or whether you go to Gillette or whether you go to Children's or whether you go to Masonic. Same thing, every place. That's what it takes. Each situation is individual. Each environment is individual, just like each family and child is individual. As an advocate, then, what you're trying to advocate for is that you have a healthcare system that can meet all of those needs and that is continuously learning and changing because it is responsive to patients and families. You can't design or redesign or recreate or reimagine your healthcare system without real collaboration, true partnerships going on between patients and families and those delivering care. And then each situation, because of its unique characteristics, may look a bit different, although they're going to honor and have fidelity with those core principles and core definitions. I've talked a lot about families. Let's just pause and talk a little bit more. Here's a great definition of families from the New Mexico legislature several years ago, saying that, look, families are big and small and extended and nuclear, multi-generational, one parent, two parents, grandparents, one roof, many roofs, temporary as few weeks, as permanent as forever. We become part of a family by birth, adoption, marriage, or from a desire for mutual support. A family is a culture unto itself. I've always loved that phrase, with different values and a unique way of realizing its dream. And they conclude, together our families become the source of our rich cultural heritage, spiritual diversity. Our families create neighborhoods and communities and states and nations and galaxies and everything beyond, So this is a big, broad way of saying that families have many different configurations and shapes. And if we're going to be responsive not only to the breadth of the children who are receiving care, but their families, we need to have a healthcare system that can embrace all of those people, the biggest and broadest definitions that we can. And we need to recognize, as they do in this definition from Christ Hospital in Cincinnati, Ohio, the word family refers to two or more persons who are related in any way, biologically, legally, or emotionally. And here's the key line. Patients and families define who is family to them. So every time I use family, I want you to think of this big, broad definition of what we mean. And I think as advocates, we have to make sure that everybody gets it when we're talking about that in what we do. Here's my favorite definition of family. A family is a group of people who make an irrational commitment to each other's well-being to the point of making each other crazy. And that comes from Bronfenbrenner, and I love the definition because to me, it says, if I want to find the family, I want to know who's got that irrational commitment. And some object to the term crazy these days. I understand that. We don't want to be pejorative about people, but what I'm trying to get at here, or Bronfenbrenner was getting at in his day, was just that it's not always sweetness and light. It's not always easy. Families are complicated. They add complication. If we're just dealing with the patient or child, well, that's one layer. If you put this big, broad group of people with an irrational commitment into the equation, it's more complicated, but it's necessary. And I'll tell you why it's necessary, and I'm going to show you data that shows it's necessary medically and clinically as well as socially. But I also remind people that we're healthcare professionals. And Rachel Naomi Remen said, to practice medicine with good spirit does not mean to be in a place where there's no noise or trouble or hard work. It means to bring your calm and loving heart right into the midst of it. And so when I'm teaching residents or talking to others, I say, and they talk about the real challenges of dealing with real families who have real complexities. I say we all need to take a breath here and be in a space where we can bring our calm and loving heart right into the midst of it, along with our professionalism and our skills and all the things that we feel like we have to offer and want to share. Every profession you work with has a statement about patient and family-centered care. I can assure you, especially in child health professionals, whether it's PT or OT or speech or respiratory therapists or others, here's something about patient and family-centered care in pediatricians' role. I had a role in working with the AAP and creating this, and so this language is out there. Is it true to the culture of what you're experiencing? And do you experience true family professional collaboration at all levels of healthcare where healthcare is received? In the care of the individual patient, to be sure, but again, as advocates in program planning and evaluation at the policy level. That is yours to advocate for and to say, there's a seat at the table for me that we need to take, and we need to know is there, and we want to take effectively because it's about mutually beneficial partnerships. I want to be your partner, and I want to make sure that people are receiving care in a patient and family-centered way as the driving force, because we know that patient and family-centered care provides the framework and strategies for improving quality, safety, and the experience of care. And I want to tell you, every healthcare leader you talk to is interested. They are galvanized by quality, safety, and the experience of care as measures of really whether they're doing the right thing in healthcare. You are essential partners in that. Because everybody is searching for the triple aim. This has been set up as what we need to achieve in medicine. We want better health outcomes. We want better care experience in the way that care is delivered, and we want lower costs. That's what the triple aim is about. Don Berwick, one of the most highly respected leaders in healthcare, founding director of the Institute for Healthcare Improvement and former director of the Center for Medicare and Medicaid Services, said the most direct route to the triple aim is via patient and family-centered care in its fullest form. That means full partnerships with patients and families in all that's done in healthcare to achieve better health, better care, and lower costs. Well, what do patients and families want to know from clinicians? What do I teach them? What do I tell them as somebody who's teaching about that? Well, I tell them, look, every patient and family who you encounter wants to know these things. They want to know what's the problem, what are the medical issues here, how can it be diagnosed, how can it be treated? And of course, every doctor, every nurse practitioner, PA, whoever it is focused on this idea of we want to make our diagnosis, we want to offer the best treatment for you. But I tell them, look, you may focus on these two things and you're missing the boat, because actually every patient and family member also wants to know, how can I contribute to the process to enhance the quality and safety of care? That's something also that every patient and family member wants to know. They want to know when and how and where will communication happen. And they want to be assured that as a healthcare professional, you're listening in an active and powerful way. And every patient and family member also wants to know, what does this mean for my family's life? In other words, I want to know what the plan is. I want that to be achieved in a mutual way that makes sense for us so that we can best continue care outside of the healthcare encounter, whether it's at a clinic, in an office, in an outpatient center, or in a hospital. We're the ones who are continuing care at home. I need to know what this means. And so a healthcare system that's structured around these four questions is one that is going to be powerfully meeting the needs of patients and families. Why don't we do it? High above the hushed crowd, Rex tried to remain focused. Still, he couldn't shake one nagging thought. He was an old dog, and this was a new trick. Well, many people think we have an old dog health system, that it just has not been adaptable and able to change. But I want to tell you, it's changed a lot. And those statements that you saw and the culture and strategies that they breed from our healthcare systems, they are fantastic examples of how healthcare systems have moved forward. But the motive force to continue moving forward in patient and family-centered ways is going to come from patients and families patiently and politely pushing and pushing and pushing in ways that say, you got that right, and you know what, this needs to be better. Or even, you were doing this and it was wonderful, and we're seeing some retreat from that, and we need to see that back, because that's where value was for us. That's where the experience of care and quality and safety really was improved for us. And that's where your leadership as partners, as advocates, makes a difference. About 20 years ago, the Institute of Medicine, now called the National Academy of Medicine, first put out a publication to Err is Human that unmasked patient safety concerns, and then Crossing the Quality Chasm, healthcare quality in the 21st century. And in Crossing the Quality Chasm, they came up with some core definitions for what are the rules for healthcare in the 21st century that are indicators of quality, that show us that quality care is happening. And the first rule was that care is based on continuous healing relationships. And as a family physician who provides continuity of care, that's music to my ears. But it's not only about one doctor or one nurse or one therapist or one social worker or whoever it is you're working with. It really is about continuity with a healthcare system that has a core of values where you can count on it every time you go, regardless of who you see. When you see somebody new, you know they are just as committed to patient and family-centered care and collaboration as the person before them and the person after them. When you check in, you feel that way with the people at the front desk. When you check out, you get the same feeling, and the same is true of nursing staff and others. And it's about healing. It's about, we can't always cure, but we can help people to get and feel better. And it's about relationships. That's the nature of healthcare. And that care is customized according to patient needs and values. And let me tell you, this scares the pants off of healthcare professionals. How am I going to customize for everyone along the way? Well, you are, if you can build flexibility into your systems. And one of the nice things is most people kind of want very similar things. It's said that 90% of what patients want is going to be really held in common. It's just a different 90% for people, and that 10% is about us and what we need, and how is our individual situation going to be incorporated into healthcare. That can be a part of the co-design of how we deliver health services. The patient is the source of control. One of the things I'll tell you that's infused in the language of medicine is we say, how are you going to manage your patient's diabetes? Well, guess what? As a doctor, I'm not managing your diabetes. I'm your consultant who's going to give you information and advice and all that. But it's the patient who's going to decide, what am I going to eat? When am I going to eat? How active am I going to be? Am I taking my meds? Am I taking them this way? And doing that, that's really where the source of control is. This just states really the facts, the obvious. Knowledge is shared and information flows freely. We certainly talked about that in the principles in ways that are useful and affirming is really key. Decision-making is evidence-based, and we all want evidence-based decision-making. Who wouldn't? The problem is that we don't have great evidence for everything. We don't have the perfect randomized controlled trial for everything, particularly for children with special health care needs who often have a highly individualized constellation of conditions that make up who they are and what their healthcare needs are. And so along with evidence-based decision-making is openness and frankness about situations where there's uncertainty. How do we share uncertainty also in ways that are affirming and useful? It's one thing to just say, well, I don't know, nobody knows, but it's another thing to say, let's use judgment together to figure out what's right for you and your child in terms of your knowledge about your child, my knowledge about children in general, How do we bring those things together to make the best decisions for you that make sense? Safety is a system property. It's hardwired in there. We have much to say. Based on the experience of care, patients have much to say about what makes systems safer. Transparency is necessary. That means everybody knows how things work and what's going on. Needs are anticipated. We're proactive rather than reactive in the healthcare system. Waste is continuously decreased. We're cost conscious, and we are resource prudent in what we do. And I always tell administrative leaders and others in the healthcare system, you want to save money? Talk to patients and families. They're the ones who know where's the value going on and what wasn't contributing value to the care that their children or they are receiving. And so they're the ones who can let you know where savings can happen. And finally, cooperation among clinicians is a priority. It's not just a nicety. It's not just we'll share charts or things like, it's a priority. It's in the structure of the healthcare system to assure cooperation among clinicians. Well, all of these things make up the quality definitions that are important to me, because quality is more than technical quality. Historically, and still today, people think of healthcare quality as, did you order the right medicine? Did you do that procedure technically right? Did you interpret that lab value properly? But no, quality is all of those factors that were identified by the Institute of Medicine as being the nature of quality. And guess what? The patient and family experience can be a driver for quality improvement. The healthcare system we all want is one that is built on safety and has as a fundamental aspect patient and family centeredness in order to assure that healthcare is delivered in an effective, efficient, timely, and equitable way. And 10 years later, the Institute of Medicine talked about learning healthcare organizations in America and talked about them as being important, and said when patients, their families, and other caregivers in the public are full, active participants in care, health, the experience of care, and the economic outcomes, that is the triple aim, can be substantially improved. I want to be as clear can be about this, because this comes up all the time. Patient and family-centered care is not just being nice. Now, nice is good. We're pro-nice. We like nice. But this is not about the amenities of healthcare. We'll build a nicer lounge. We've got a bed in the room of children now that family members can stay in, which is a wonderful thing. It's an outstanding thing. You know, I just love the fact that that has happened, as opposed to needing to force yourself in to sit next to your child's bed all night. So that's good. But patient and family-centered care is not just being nice. It is a direct and intentional effort to unequivocally, mark that word, unequivocally, you can't miss it, communicate to people and their families that they are viewed as distinct and valuable individuals with a family and a place in the community. And again, the key here is that relationships between individuals, families, and providers are essential alliances and partnerships, with each bringing expertise to decision-making to improve care. That's what we're all about. We're about improving care. Certainly the care for the children we love, so our children, but for all children, and the care environment for those who deliver care. We want to be partners and allies in that. What does it take to do that? Respect and dignity, information, participation, collaboration, those key elements. And if you boil it down, it's this. Patient and family-centered care is working with patients and families rather than doing to and for them. And what we constantly challenge organizations to think about is, how are the with skills going? How is it going for professionals to know that they are supported, have the environment, the training to be great with clinicians in what they do? And that notion of to and for is not the way that they're thinking in terms of the care that they're delivering, but they're always doing this in partnership. Now, here's one view of partnership. This was the cover of the British Medical Journal in 1999, Embracing Patient Partnership. I am not recommending this relationship for you with your healthcare providers. This is not the official Institute for Patient and Family Centered Care's recommendation, but they use tango as the metaphor for the intimacy of the dance that it takes to do this well, to truly embrace partnership and be real and meaningful partners in all that we do. It's that intricate to make it work well. It's about collaboration. Collaboration to co-labor, to work together. And collaboration means that no one interest group is always right. It means taking what you think and what I think and what someone else thinks and coming up with something that works for everyone. That's our friend Bev Kreider, who talked about this as a family leader, that we don't know, that's that idea of we don't know where patient and family-centered care is going to take us, because it's a process map. It's a way of relating to come up with solutions as opposed to prescribing solutions to patients and families and clinicians. Here's another definition of patient and family-centered of collaboration: an unnatural act between non-consenting adults. We're not that good in healthcare with collaboration. We're not that good at working together as interdisciplinary teams or doing interprofessional education. We're trying to elevate that. We know that it can actually be hard to do. And so oftentimes I'll hear systems say, you know, we want to get our act together and then we'll relate to the patients. We don't want them to know that we don't have it totally together. And I always say, guess what? They know. And the challenge I give them is to think about this. You know, who is the parent and family or child in your thinking? Are they the adversary? You know, oh, we got to deal with those parents along the way. Or are they the patient who you are focused on and doing to and for? Or are they your partners? And people love patient family partner. That's great. It just rolls off the tongue. But I also want to be clear about this. Partnership depends on the terms of the partnership. You know, I can say we're partners. I tell you what to do, you do it. That's partnership. Well, if that's the terms of the partnership, that's not truly collaboration. Or are they your colleagues? They know things that you don't know. You know things they don't know. You come together to make the best decisions. Or do you even think of them as your employers? They're the ones who are paying for the healthcare here. They're the ones who should be getting their value from it. And so this idea of patient and family-centered care undermines, it's the foundation for safety and quality and satisfaction and finance and all the things that healthcare organizations are about. And patient family-centered care then needs to be woven into the construct of every element of a healthcare organization. Yes, it's about care at the bedside or sharing information, but it's also about how human resources are done, your quality systems. What about the chart and how that's shared? How is professional education delivered? Every element of that should have patients and families as colleagues, as essential allies in the way that they're developed and the way they're delivered. A century ago, Franz Kafka in the wonderful story A Country Doctor said, "To write prescriptions is easy, but to come to an understanding with people is hard." This is hard work. Collaboration is not easy, but it's valuable work, and it's actually medically essential to come to this understanding and to bring people in rather than to separate and exclude people. Why? Well, we know that social isolation is actually dangerous. We have data that says social relationships, or the relative lack thereof, are a major risk factor for health. In fact, there's a recent study that says social isolation is the equivalent of about smoking 15 cigarettes a day in terms of adverse health outcomes in what happens. And we know that social isolation is rampant among children with special health care needs and their families. We know that adults, over 50%, report no regular social interactions with people who are not related to them or paid to work with them. We know that children with autism have trouble making friends. We know that families of children with autism and other disabilities indicated that they feel isolated and actually sometimes isolate themselves in social settings because of the challenges that exist in their family with their child with special health care needs. They don't feel connected. That has real implications for health and quality outcomes. And there's a whole happiness science going on now, recognizing the importance of social connectedness with other people. In fact, social connectedness is now known to be therapeutic. If you look at things like mortality risk, survival is 50% increased in its likelihood for people with stronger social relationships than those who have lesser social relationships, regardless of the condition, age, sex, cause of death, other things. Social connectedness actually builds on health status, and the absence of it is a danger that we need to recognize. So our healthcare systems need to be designed in ways that promote social connectedness in what we do. We talk about this, if you're talking to a healthcare professional, they've heard of the social determinants of health. And if you look down that middle column to sort of the second box, clinical care, that's what I deliver as a doctor. Guess what? Access to care and quality care make up only 20% of the determinants of health outcomes in terms of length of life and quality of life. All of those other factors on the right, health behaviors and social and economic factors, the physical environment, family, connectedness, community, all of those things make up the other 80%. And that needs to be valid across all cultures and needs to meet the needs of people with different linguistic approaches as well as cultural backgrounds in all we do. I want to share with you something from my wife and I as people who've had experiences, the parents of children with special healthcare needs. Many years ago, Star Trek, William Shatner, who now you see on late night TV hawking whatever, was Captain Kirk on Star Trek with Leonard Nimoy as Spock. And they had something they referred to as the Prime Directive, a guiding principle for the United Federation of Planets, prohibiting them from interfering with the internal development of alien civilizations. As trekkers ourselves, my wife and I, as our children were young, said we need to live by the Prime Directive, that the best thing for our children is to have healthy, happy parents, that social connectedness, that relationship to our world as individuals and a family actually was important for us and had important therapeutic outcomes for everybody in what we did. And that was what we lived by, and I certainly encourage that for you. So it is about better health and better care and lower costs. But now we talk about the quadruple aim. We also want to improve the experience for those delivering care, as well as for those of us who are supporting those receiving care. And that's about wellness. And the World Health Organization says wellness is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And so this is about you as family members, as parents, as supporters, as advocates, as people who are connecting with others. You need to be resilient, and resilient means that you have adaptability, and social connection builds your adaptability. So our healthcare systems, again, need to not be inadvertently creating isolation or division. They need to be promoting social connection so that we have that positive outlook and that we can align with a feeling of purpose. In my healthcare system here at the Department of Family Medicine and Community Health here at the University of Wisconsin, we've developed an integrative medicine program that talks about whole health for anyone, not only receiving care, but delivering care. And so, and supporting those who receive care. So again, this is just a pause to say, look, in all of this advocacy you're doing, take care of yourselves. In what you're accomplishing, remember the Prime Directive that your health and your well-being is important, and acknowledge that this actually has health outcomes for all of us if we enhance our social connectedness and avoid that isolation. Back to Wendell Berry. When despair for the world grows in me, and I wake in the night, at the least sound, in fear of what my life and my children's lives may be, I go and lie down where the wood drake rests in his beauty on the water and the great heron feeds. I come into the peace of wild things, who do not tax their lives with forethought of grief. I come into the presence of still water, and I feel above me the day-blind stars waiting with their light. For a time, I rest in the grace of the world and am free. Make sure that you have those opportunities to rest in the grace of the world and to feel free wherever that is. And then return strengthened and renewed to your advocacy. And why aren't the healthcare systems patient and family centered in the ways that they want to be? What causes us not to move forward with the things that we care about? Well, Yogi Berra said, I didn't want to make the wrong mistake. We're sometimes timid in going forward because we're afraid we'll make the wrong mistake. So I want to offer you these rules to live by in thinking about patient and family-centered care. First, attitude is everything. How you approach things is critical. Your attitude defines so much about how patient and family-centered care can be delivered, and that's really important for clinicians as well. Values determine outcomes. I say to healthcare systems, if you value it, you can put the resources there to create the outcomes. And the same is true with you. If you value this as something that's really essential, those outcomes of more patient and family-centered care can happen. All families have strengths. All families have strengths. All families have strengths. All families have strengths. That is central to this view of how healthcare should be delivered. Sensitivity, though, doesn't mean psychoanalysis. You can be empathic and supportive without telling people that they're messed up somehow. What we want is we want people who give us support and connection. We don't need more labels unless there really are major issues going on. Case management is not the answer. We're grateful for people who are there to help us through the rapids on the journey that are there for us. You know, we appreciate what they're there for, but that's not the answer. I tell everyone who's in a case management or care coordination role, your job is to get yourself out of business. Your job is to figure out where are the friction points and solve them so that people can deal with these systems themselves and not need a guide to get them through, a case manager, unless they want. And sometimes we do want someone else to do things who can do them competently and caring with knowledge and connection to us. But essential understanding in this is that patients and families are the experts on being on the experience of being service consumers. And if you're not taking advantage of that, you're missing something in their healthcare systems. You know, I get a chance to speak here and there from time to time, and my family members will say, you know, gee, I heard you went there and you went to Minnesota and you did this and that. What were you talking about? And I said, well, I talk about patient and family-centered care. And they say, what's that? And I say, well, it's talking about how people receiving care should have a role in the design of the healthcare systems they're experiencing, being welcomed into that by people who are providing care. And they look at me and they say, people ask you to go talk. I mean, they pay you sometimes to go talk about that. It's so obvious, yet it's so difficult. And finally, the person with the most flexibility will be the catalytic element in the system. What I challenge healthcare professionals and leaders and administrators to do is to be rigidly flexible. If you're going to customize care, then what you must do is you must rigidly create systems that accommodate everybody, that are flexible and can make sure they meet the needs. If you want to stop a runaway stage, you can have method A, which is organized, or method B, which also stops the runaway stage. Now, if you want to continue your journey, I'm choosing method A. You got to come up with a plan. So I'm going to tell you some tricks of the trade humbly, because you don't need to really hear them from me, and just some thoughts. And these are things that I teach in the work that I do. First, treat each person as an individual. You don't need to hear that from me, but it's true. I want every clinician to respect you and your child as individuals, and you to respect them as individuals. I want that respect about patient and family knowledge about their own health needs to be woven into the way that healthcare is delivered. And I always tell healthcare professionals, meet patients and families at their models of the world. Get to know how they're looking at things. You're entering their lives. I talk about participating in a men's group once of families. I was invited to sit in on this session of parents of children who were in the NICU, and this was all fathers. And they said, you know, it's so amazing what they do in an NICU. We walked in, open arms, they embraced us, and they said, look, you know, here we are. We know about caring for these premature infants and these little babies and what they're about. Welcome to our world of the NICU, and we are going to support and nurture you. He said, as much as I appreciated that, this one father said, I wanted to say, no, you got it wrong. He said, no, welcome to the world of the Smith family. And we have our family and our friends and our community, our faith, our world, our all of those things. And now we have you, and we have this child, and you're coming into our world. And that's the reminder that we have to keep giving to our healthcare professionals. Share knowledge and information. We talked about that. Avoid labeling. People don't want labels. They want support. Assist in problem solving. Healthcare professionals are good at that. That doesn't mean solve problems for people. Teach choice, because there's always choice. Honor natural supports, which means recognize that patients and families have those in their lives who often are the ones who are going to support and assist them. See, I don't know when you don't know. That's that flip side of evidence-based care. It's being honest about uncertainty and then say, let's find out together, or here's how we're going to make or maybe approach decisions in the best way we can. Develop roles for patient and family consultants. That's you. Consider functional issues in a gradual but systematic way. How are people living their lives and what help do they need? Create alliances with other professionals at a personal level. Partner with people in real ways. Make the primary care specialist relationship work. That is, don't put families in the middle unless they want to be of specialty care and primary care. Make sure your staff knows about special needs. I'm hugely guilty of this. I'll say, oh, just give me a call if you've got a problem. And then we have all these layers of systems in between me and the call you're making about things that I've set up my staff not to recognize that I said, no, I want this access for this family. Anticipate cross coverage. There's not only going to be one person, there's going to be that person and that person. They all need to be in a patient and family-centered mode. Develop financial creativity, nothing illegal, of course, but recognize that there are real costs here and that we've got to know where a family's coming from and how can we support that. And finally, make talk time available, because patient and family-centered care can be talk intensive, at least at the start. But you know, when you come to an understanding with people, you often save time at the other end. And so while professionals are worried about talk time when we talk about it, I tell them this is going to help you in the long run, and it's going to be more satisfying in the way care is delivered. So I hope I've helped you look at healthcare and patient and family-centered care through different glasses so that you have maybe a little different take on what we mean by that. And as I conclude, since I know you all have children in your life, I'm going to talk about, as I always do, the toddler property laws, because toddlers have such a unique way of looking at the world. To a toddler, they would say, if I like it, it's mine. If it's in my hand, it's mine. To a toddler, if I can take it from you, it's mine. Or if I had it a little while ago, it's mine. To a toddler, if it's mine, it must never appear to be yours in any way. And certainly, if I'm doing or building something, all of the pieces are mine. A toddler would say, if it looks just like mine, it's mine. And of course, if I saw it first, it's mine. Or even if I think it's mine, it's mine. But if it's broken, it's yours. Our healthcare system is all of ours, whether it's put together well or if there are parts of it that are broken. We can work together to make it better for children and families. So that's the end of my formal presentation. I have, 5 or 10 minutes or so if there is discussion, but you've got more to do too, so I can bow out. So if there's any questions, comments, clarifications you're seeking, just has been a great pleasure to talk to you.
So, excuse me, thank you so very much. I know that I've heard some of that information previously, but I always get something out of it every time you present.
Well,
and it just builds on our knowledge of patient and family-centered care and how to make it a reality. So I thank you so very much. I would like to open this up now to everyone who's on the call. I did end up muting a couple people. I've unmuted you now because I don't think you were aware that your lines weren't muted. But I would encourage anyone to either ask a question, or if you have any comments or pieces of this that you feel were especially helpful to you at this stage of your family leadership, to please chime in. You can also chat in the chat box, and I will read your question if you don't want to come on and speak live.
Hey, Bill, this is Jamie O'Connor, and I want to echo what Tricia said, but just said that sometimes, well, often, I think all of us are quite tired, and hearing you present in this way, which is pretty creative and energetic, really does transfer over and re-energizes us. So thank you.
Good, good. Yeah, and pause and make sure that you're recharging yourself, Jamie. It's just critical in what we do. You know, living life is hard work. Parenting your child is hard work. And now we say, oh, and be a family leader too. That will be easy. Well, it's not always easy, but it's very rewarding. Take care of yourself.
Thank you.
Well, good. I'm comfortable with this. You know, I often give presentations to people and I ask it, you know, or they do because they're being polite or something like that. This is not that kind of presentation. I didn't give you things that are terribly complicated, you know, like, what did you mean by collaboration? You know, it's not that. This is sort of like something to percolate in. Let it soak in, think about it, ask yourself, what's my framework? How am I living by core elements and values in what I do? What am I taking to the table? And I also wanted to give you that little insight to say, you know, this is where the state of the art is for those who you're talking to. They know that there is this world out there of we should be partnering better and more. They're looking to you to some extent to tell them what that partnership looks like. And you'll be great advocates because you're learning from some really outstanding role models in Carolyn and Tricia. So congratulations to all of you.
Thank you, Bill. I think that the collaboration piece has been one that I've found the most helpful as a tool because, you know, when you first learn about patient and family-centered care, you get all excited and energized to authentically partner with these large systems, and the how can be a challenge sometimes. And so learning about collaboration and how to actually do that, I think I've learned a lot from you, I've learned a lot from Carolyn, and I've learned a lot from other parent leaders that I've watched and talked to about how to truly collaborate with those individuals and professionals and providers in my child's care, rather than kind of go in guns blazing, I know about family-centered, patient and family-centered care now. So I think that, you know, revisiting some of those elements of collaboration have been really helpful to me in just this journey of family leadership and authentic partnership.
So, and one of the points that I want to make is that, you know, here you are thoughtfully teaching collaboration to these fine people. Guess who didn't get that lesson? Some of the people they're collaborating with. And so one of the pieces as leaders to do when you're coming in with audacious notions like, you know, family members on safety committees or something like that is to say, how are we going to help the people who haven't done this before to say, you know, what are the rules of engagement? What is it like to do collaboration with patients or family members from their end of the equation if they've never had that experience or they don't know what it's about. And who better to teach them than you? And who better to help them develop that than you? But ultimately, yeah, their leadership's going to have to say, this is important to our outcomes to get better quality and safety, and we need to learn how to partner better on our side with these family members.
Absolutely. Does anyone else have anything else for our presenter today?
I do have one thing I just wanted to say. This is Tony, by the way. Bill, I wanted to say, first of all, thank you for the time that you've given to us. But when you and your wife created the quote, of course, the best, I might not have it correctly, but the best thing for our children is for them to have happy and healthy parents. That is so true. And I think of the, oh gosh, I think everyone has heard on the airplane when they say, put your face mask on or your oxygen mask on first before doing it for your children. It's so true. I think if all of us could realize that that self-care piece is so important, not only for us, but mostly for our kids and our family, I think that helps, because I don't know about, I'm sure all of the other folks on here have always said, well, I don't have time for self-care. But really, if we think about it in the way that you and your wife have thought about it, I think we'd all do very well.
Yeah, I think, we, like you, I'm sure, we were going to be the perfect parents. Every therapist gave us, the OT gave us stuff, and the PT gave us stuff, and the speech therapist gave us stuff, and other people gave us stuff. And, we were going to do everyone every day because we were going to be the perfect parents. And of course, you can't do that. If we did everything that got piled onto us, that was hours and hours and hours, and we couldn't do it, and then we felt guilty and bad, and first of all, we then became advocates to help people say, you're all giving us stuff, how about y'all get your act together and let's get something together here. But aside from that, we had to recognize that that's important. Just as with our typical child, we were going to have the tear-free childhood too. We're going to be the perfect parents, and she was never going to suffer for a moment of her life. And we all have to get over that as well. And so, but giving yourself permission to have that balance and to be the one who decides what that balance is, and not to be responding to externalities about that, but knowing in your own heart and sharing it with people you feel confident sharing it with, I think that's just critical in what you do. So I hope that is a good framing for you.
Thank you. Yes.
Hi, Bill. This is Mary Roach.
Yeah.
Thanks for your time.
Sure.
I'm coming across some clinics that are having assigned patient responsibility forms. And one of the things on there is that me as a parent will do this home training that therapists are giving us to do. So like you said, we don't have the time to do all of that, or our child won't comply to do it with us. So how can we, or what's your advice to step up to those responsibilities that they're wanting to do?
This is a great discussion, Mary. There has been this thing going on. We talked about that quadruple aim. What's the clinician experience of delivering care, and how can we be more supportive of clinicians who are delivering care, because we're seeing burnout and all of these things. And to those therapists, they're feeling the pain of, look, we have difficulties with access, we have difficulties with all these things, and I have some families where I feel like I do my work, but then I say, here's what needs to happen if you're going to continue this, because the work of therapy doesn't happen all in the therapy room. It's got to be continued on. And if you're not going to do it, that's a waste, if you will, of your time and my time to come here, because you're not going to get the outcomes you might hope for. And so in response to that, they've come up with these, well, we've got to be clearer on our expectations of patients and families. And you know what? I don't disagree, first of all, of being clearer with what you would hope for as being expectations and explaining what the therapy process is about, that this won't do you any good unless you're also doing it there. I'm all for that. But in the way this is being implemented, it's not being implemented in patient family-centered ways. And that's where you as leaders can say, you know, I get that there's something here that's important and that's of value. And we want good clinician experience and we want the system to work well. But if it's coming back at patients and families in ways that really aren't supportive of the patient and family-centered value, you need to know that that's how it's landing and that that is not feeling consistent with that value structure you've given. So let's work together to figure out how we can convey the point that is being made here and do things that are supportive of our clinicians and of access to care and all the things that are challenges in ways that are affirming and useful to parents and families. And I think if we can partner around that, some of this push that we're seeing can have a different tone and a different flavor in it.
You know, that's really a great question, Mary, and I'm glad that, Bill, you were able to respond that way. It leads us into the next session that Carolyn's going to do for us that talks exactly about parent-professional partnerships, to how to that piece. And so I hear, Bill, you called out some communication there,
yeah.
And Carolyn will be talking about communication and collaboration a little bit more too.
Good. Good.
I do
well, I'm going to step off because I've got another thing I got to do. But anyway, really just a pleasure, and I just applaud what you're working on, what you're making happen for your families, your friends, your community, and all that you're doing. Thanks so much.
Thank you for your help in that. Don't forget to stop sharing your screen.
All right, I am gonna. It's hard for me not to share. Telling me to stop sharing, I'm not good at that. But I will do that. I'm gonna leave the meeting then, and y'all have a great day. Bye-bye.
Thank you, Bill. All right, folks, I hope you enjoyed that, and I'm praying that my computer has enough memory to hold this entire recording, because I can't hear it enough. Just as I go through this journey, you know, feeling like it just builds. My brain gets kind of full, but then when it opens up, I hear Bill speak again, and I think, yeah, this is how it can work. So we were going to move into a bit of an interactive discussion for this part. Carolyn, do you want me to share the screen, or do you have it up? I can do it. And it's going to be based on some of these principles that Bill just talked to us about recognizing the driving forces. So, can everyone see the activities, the quiz? Carolyn, I will let you take it away if you'd like.
So I think Bill gave a pretty in-depth description of each of these different driving forces. He talked about system-centered care, where the needs or the benefits to the system drive the delivery of care. He talked about patient-focused, where the staff focuses on the strengths and needs of the patient, but not seeing the family as a potential partner in care. He talked about family-focused, where families are sort of the unit of intervention, and that doesn't mean that there's collaboration. And then the idea of what truly patient and family-centered means. And, you know, I think obviously the whole presentation was focused on describing that. We have a little quiz that we thought we would do. in which we have some questions, and we'd like you to think about whether the sort of scenario that we're presenting in each one of these is system-centered, patient-focused, family-focused, or patient and family-centered. So the first one is a physician and nurse coordinator create a plan of care for a patient with spina bifida. So I'm curious about what you think the driving force here is. Any ideas?
Give you a little hint. I know this one is, the key is in the word. They create it for the patient.
So patient-focused?
Yeah, I would think so. I think either we could say it's patient-focused or, you know, family-focused if we don't know what the age of the patient is, but that's what I would think, because it doesn't talk about whether or not the family or the patient has been involved in creating that plan of care. And if it were family-centered, it would be the family and the patient and the physician and the nurse coordinator all working together to create that plan of care. So how about go ahead. No, go ahead.
I was just saying, whenever somebody hands me something, well, I wrote this up and I put it all together for your review. When it's about my child, I think, gosh, you know, we could have made it a lot further on this if we would have sat down together and done it together, versus you put together what you think and then tell me to just mark it up. That's how I feel.
Yeah. So the next one is Hospital Staff Education Committee updates educational material about brain injury for patients and families.
Any guesses on this one?
I would say system-centered.
Yeah.
I would tend to agree with that.
Mm-hmm.
Why do you say that?
Well, it's for the material, and so it's not really involving any direct individual or family. It wasn't specific. It was just like, here, pick up this pamphlet if you want to. We're offering it to you.
Mm-hmm. And that's obviously not to say that educational material isn't important, but I wonder what role can patients and families play in creating educational materials, and how that might improve how they're received and how they're viewed.
Right. So we say a lot of times, you know, it's the patient and their family that knows where the gaps are because they're experiencing it. So, you know, may I tell you, or may I share with you where I could utilize some more support, information, or help? And I'm sure a good hospital staff education committee that is practicing patient and family-centered care has those patient and family advisors on that committee helping them determine those things.
And I mean, it's nice to have something to take home after an appointment, you know, a brochure or handout, but a lot of times I pick them up and I think, well, that doesn't really fit for my situation. So who do I talk to now? Or I already knew more about this than is in here. So, you know, what's the next thing?
Mm-hmm. That's a great point.
Great, yeah.
How about the next one? A physician and nurse co-lead a support group for patients who have diabetes.
Feel free to shout something out or type something in, because most of these could probably be more than one.
I would say possibly patient-focused or lower, system-centered. They're not including any family members of those clients who have diabetes. And it's just a physician and a nurse who's leading it, and they may not be living with diabetes. They may know technically everything about it.
Yep.
Exactly.
So how about the next one? The clinic administrator invites patients and families to comment on the final, oops, I skipped one. Well, we'll do this one anyway, on the final plans for renovation of the facility.
I would say system-centered because it's the final plans, so it's too late.
Yeah. Yeah, I would say so too.
I would say so as well, and I think that, you know, if you look at patient and family-centered care principles that say you need to partner with families, starting at design, implementation, evaluation, redesign, implementing something again, and reevaluating it. If you have those families in at the beginning of that process, you might save yourself some money and some time and effort creating something that wasn't even a true need. Like Bill said, you know, the consumers and the users of the services are usually the ones that can tell you where the value lies.
Well, and also where the needs are.
And the needs, yes. Did we even need a new waiting room?
I'm reminded of years ago a project that I was involved with at the Minnesota Department of Health, in which we brought together teams of physicians, nurses, and families from different clinics to work on making improvements. And we had a nurse and a doctor who chose their parent partners to be on their team. But before they met with the parent partners, the two of them sat down and they made a list of things that they felt like really needed to be improved at the clinic. And so then they invited the families to come in and meet with them, and they sat down and they presented the list to the families. And one mom said, well, this is a good list, and yeah, these are all things that could be improved. But you know, it would really help me a lot is if there was an automatic button or for automatically opening the door into the clinic, so that it's easier for me to get my daughter in her wheelchair into the clinic. And the nurse and the doctor, they were just stunned, and they said, you know, this is a brand new building. This building was just built, and there is, you know, doors with automatic doors into the building. And the mom said, well, yeah, into the building, but into the pediatric clinic, there is no automatic door. The physician and the nurse had no idea because they come in a different entrance. They'd never come into the front door of the pediatric clinic. And so that was the first thing that their team worked on, was to get money to put in an automatic door. And it's just an example of what families bring to really looking at the needs in lots of different settings. So let's go back and go to the one I skipped. Patients and family members teach an orientation class for all new clinic staff and physicians hired at the clinic.
What do we think here?
Well, for this one, I guess I'm looking at it and I'm wondering why it's the patients and families that are actually teaching. I guess it depends on what they're teaching. Orientation class for the staff and physicians, are they trying to orient them to how their families are going to need their services? Or, because then I would answer it differently depending on that. Does that make sense?
Uh-huh. So I think that it, obviously it's not defined here, but I know of a hospital that used to do this. I'm not sure if they still do, but whenever there's a new cohort of new staff, the patient and family members are part of an overall orientation to that hospital system. And so it includes the idea of what is patient and family-centered care and the role of families in that hospital system.
And that makes sense. So maybe not patients and family members teaching it, the orientation, but maybe they're participating in it. And then, of course, I think I would say patient and family-centered would be the answer. Maybe not. I
think so.
Okay.
But I do think that, and I don't know, maybe it's confusion in the way it's worded, but patient and family members very much can teach. They can very eloquently teach staff and physicians and medical students and residents a lot. And I think that's a very important role that families can play as part of patient and family-centered care.
That is true.
You know what, Tony, this brings up a really good point, too, that a lot of this depends on how is the system intending to utilize this. How are they intending to utilize the information or the process? Are they hoping to check a box to say, yep, we consulted with families, or do they truly care about and value the expertise that the families bring to the table? So I think that might be a piece of the information that we're kind of struggling with here. But, I'm going to share this entire document with everyone because we have a couple that we're probably not going to have time to get to if we want to end on time today. But we'd be happy to chat more about it. I wanted to make sure that we took a few minutes to update on some important things coming up and then also answer any questions that anybody who's participated today might have. So the first thing is that our next two sessions, sessions 5 and 6 for March and April are set. We do have dates. So session 5 is going to be parent and professional partnerships. And that will be on March 11th at noon, from noon to 1:30. And then we have session 6, the history of disability in Minnesota, which will be April 8th from noon to 1:30. And I know a couple of you have heard Colleen Wick present before, but kind of like Bill, you can't hear it enough. And I've heard her present on this very topic, and I think it's so important now more than ever in our family leadership journey to revisit kind of where we've been and how far we've come so that we can continue to broaden our vision as we move forward. Jamie, do you want to share about another webinar we have coming up that has quite a bit of popularity already, tons of folks registered? Well, I'm sorry, it looks like Jamie had to potentially jump off. Carolyn, do you have that pulled up?
Hold on for just a moment. So we have a webinar coming up on healthcare options that's being presented by a representative from the Minnesota Department of Human Services. And I have to find the date. I'm sorry, I don't have it pulled up.
I apologize. I have so many things pulled up on my computer right now. I'm afraid that if I start looking for that, I'm going to lose everyone. It is, well, hopefully all of you are signed up for our newsletter. Because in that newsletter.
Oh, sorry.
That's okay. In the newsletter, you will see information on all of our upcoming webinars. Tony, I know you're looking it up too.
Yeah, I have it here. It's actually, I believe, Carolyn, you might have seen it. It's Wednesday, March 4th from 12:30 to 1:30.
Yeah. So it's going to be on understanding medical assistance and TEFRA and waivers. And yep, so March 4th. Thank you, Tony, for pulling that up. And if you are not currently receiving our newsletter, please let us know and we can add you to our email newsletter list.
It only comes out about once a month, so you won't get too bombarded. You can also check our website where we, list all of these. You can register for them there. I really encourage anyone, even if you're not currently on a waiver, sign up for this webinar because, my son was not on a waiver for a very long time just because I didn't have proper information. And this might help you either for your family or the families that you come across and support in different ways to understand a little bit more the process and the ways that it can be a support to families. So I encourage that.
And then we also have another webinar on Tuesday, April 7th that's focused on the early intensive developmental and behavioral intervention benefit, the EIDBI benefit.
We'll give you more information on that one too. That's going to have some really great info and resources that I think are just not all that well known. So we've got some exciting things coming up. Any questions or comments today from any of the participants?
I thought Bill was a great speaker and his presentation was amazing just because it seemed very, it's just really friendly and had such perfect information and he presented it in a really great way. So that was nice.
We're very fortunate that he did this for us because he is definitely a leader and very well recognized in the field of patient and family-centered care. So we were very, very fortunate.
I have a quick request. We're going to do a grant for the first time. First time I learned about it at our annual PCA assessment, after how many years having these assessments, that our son is eligible for a grant. And so I guess it's based on his OT recommendations and his needs, but not having any experience, is there a resource somewhere that might have a list of things that have been approved? Does anybody know? An online list?
Mary, yeah. And you know what? I'm so glad you brought this up because here at Family Voices, many of our staff and our volunteers have all been recipients of the grant for their child. And I'm not sure which grant you're talking about. We'll need a little more information of whether it's consumer support grant or family support grant.
Family support grant. That rings a bell.
Perfect. We can connect.
They came to my house without any literature and not even an application. So they all say it's online. That's horrible.
You know what? Why
family centered?
Exactly, right? Why don't you and I follow us, and then I can get you some actual links to information and someone who's actually utilized the Family Support Grant, who has a child who looks very similar, and maybe you guys can share ideas and resources about where to find those things that would be covered.
Okay, thank you.
Yeah, of course.
In the chat box, I just put a link, and then maybe you can follow up with Tricia for more information, as she suggested, to connect you with somebody who's used it. But if you click on that link, it will take you to more information to get you started.
Yes. I apologize, folks. I have to leave. I got a doctor's appointment for myself today. Got to keep Mama happy and healthy, right?
Right.
So I'm going to take off. I'm going to end now, but I want to thank you so much for your participation. And as always, please let me know